Hi, good morning from Brazil. Just to test, Johnny, tell me if you hear me well. You can say me or by video or by chat. Just confirm to me that you are hearing me.
Yes, I hear you very well.
Yes, thank you. So let's start, and the others that are coming continue when they get in. Let's start.
Okay,
Share my screen. If you want to interrupt me, please feel free to make me questions during the presentation. And we will start. So, where are you from, Johnny?
I'm from Lebanon. I have a practice in Beirut and in Dubai.
Oh, very good. So, and have you been using OccluSense?
I have it. Yes, I use it.
Very, very well. So I will show you some details from the devices and how we can link this device with other digital tools and how we can put all this data together. Okay, let's start.
Great. Yes, thank you.
How to get better results with OccluSense. This is the point that we can understand how we can improve our practice with many different tools that we have today. The sensor, before we start to show how we can use, it's very important to understand how it works. We have many details that are very important to interpret the data. So we have the hardware and the sensor that capture and transfer this data for the hardware and then processed by the app. So the most important here, the core of the system is the sensor. The sensor is made by two sheets of papers with some electrodes between them. And all this complex, these two sheets and the electrodes make a sensor with 60 micrometers of thin. This is very thin when we compare with a paper, a normal paper of 100 micrometers. And these papers are coated with transferable colors, and we can relate the mark on the teeth with the informations that are showed us in the app. And each of these electrodes, they made 1,018 points of pressure, different points of pressures. And each of these points can provide 256 different levels of pressures. It's a lot of information that we receive from the system. And the core is how to filter and to understand so many data that we receive. This is the point. And this sensor is also flexible to adapt to different anatomies, teeth anatomies that are very important. So we see that we have a very sensible tool, and we need to understand when take off some informations and when use all these informations together. And how these data are processed. The first point that we have to understand is that about the colors. The colors of the columns depend on the diameter of the contact area. More punctual contact we have, more near to the red color we have. So what we desired in dentistry is to reach red contacts, because are punctual contacts, and this is what we desired and what we aim when we make some adjustment, for example. And they hide the other information, and one step before. The more punctual, it's ready. And when we have surfaces, large surfaces of contact, we have green contacts. So, for example, if I have some eroded teeth, I tend to find more surface of contact instead of punctual contacts. So it's important to understand this. And if I'm doing some adjustment, my aim, my goal is to have punctual contact. And if I have a green contact, I need to straight to diminish this contact, this surface of contact, to reach a better relation between these teeth. And the other point that we need to understand is the height of the columns. It depends on the intensity of these contacts. So higher are these contacts, more intense are these contacts. So what I want is to have punctual contacts in red, and the same intention, the same height of this column between the back teeth, and a lower intense in the frontal teeth. So this is the ideal occlusion that we look for when we are making some adjustment. And what are these other contacts that are showed here? These are false contacts. When we put the sensor between the teeth, we need to modulate, to adapt this paper between the teeth. And as the sensor is so sensible, what we have is that we can take some contacts that are not really contacts. They are false contacts because of this adaptation of the paper. This we can see here, these smaller columns, and when we see normally in green, these are not real contacts in this case, where we have a lot of high columns. Okay, maybe we can interpret this data in a flat occlusion by erosion, but in this case where we have punctual contact, this is not a real contact. It's only a false contact because of this adaptation of the sensor. Okay, and to end this explanation, we can compare the percentage of the contacts between the sides. This is very important when we look for a balanced distribution of these contacts and these intensities. How the system calculated this percentage? It takes 100% of the contacts and then divided in percentage in relation of these 100% contacts, and then distribute this contact. So we will use all these functions during our analysis, but we have to understand when it's useful to take off this information with the filters, for example, and how to make some decision, and where I will adjust and how I will adjust this contact with this information that the system gives us. So the challenge today is to use many different digital tools and put all these informations together. And what I have heard here from my colleagues is Why do I need to have an OccluSense to use an OccluSense if I have a scan and this scan gives me an occlusogram and I have the same informations with the scan? It's not right, this thinking, and we will understand why and how these tools are complementary one another. So here I have one case analyzed by the software, by Mesh Mixer. It's a free software that we have used to make some occlusal analysis, and I will show you more about this in other slides. And here I have the first contact for this case. This is the registration in reference position, and here I got the first contact. And I can reproduce this first contact with the scan. Yes, I have here the same contact I have here. And the scan gives me the option to activate the occlusogram and understand how are related these teeth and which are the possible contacts between the arms. The point is, when I activate when I don't use the occlusogram, I have the real contact only here at the second molar, that it's in red. This is what is this information? This information is telling me that the meshes from upper and lower jaw are in real contact. Okay, when I activate the occlusogram from the scan, the system, the software of scanner, what I have some more informations. What are these informations? This is scale for these colors, and this scale is in millimeter. What I have is that 0.2 millimeters is it's about 200 micrometers. 200 micrometers is the thicker, it's the thicker paper that we used in normal clinical check. We can understand that more than these, it's for protect spaces. It's not for occlusion analyze. This is very, very important. It makes a great confusion when the colleagues use this information with different views. These scales were made to help us to understand if we have protectable space for our pieces. And for occlusion analysis, we will use only until 200 micrometers or 0.2 millimeters. So the only contacts that interesting for us here are these orange contacts. The other will not happen in the mouth, okay? And when I analyze a scale, a contact that can happen between 0 and 0.2 millimeters, we have a very large possibilities of contacts that are happening with different intensities that are happening in these different contacts. So it's a very wide information that it's not refined to make some decision. So some softwares from some scans, like Trios from TreeShape, we can adjust this scale for 100 or less. We will see that we can adjust this scale for less than 200 micrometers. and then have have the information, have the other ranges, and then understand how to use this occlusogram for occlusal analysis. Okay, but with this this scale, that a preset scale that came with the softwares, we don't have, we cannot use this information for occlusal analysis. Let's see. As I have only orange contacts that will happen here. What is this? If I put, this is the distance between the meshes, but if the patient makes some more force, we have muscle activity, this contact can happen. This is what we see here. When I look, when I get this in this contacts with OccluSense, I have that first contact that is here, that is more intense, and I have the other contacts that are in orange with different intensities. So I can understand that more than this here, I get this information as a frame of this occlusion. I register one side and then another side, and then the software calculate this distance, this possible contacts between the meshes. But here I have what happens in real time. Why? Because I have, this is a frame from our capture, just to show you that we have a correspondence between the data that we find, but the aim here is to show you that these different contacts in orange have different intensities also, because this range is very large. It's from 0 to 0.2 millimeters. And here we can see the difference between them. But when I do this registration with OccluSense, I have more information than when we get this occlusion reference with scan, because OccluSense, it's the only tool that gives us the dynamic of occlusion. So I can see the initial contact, how this contact slide between the teeth, and then when this patient reaches the maximum intercuspal position. This is very, very useful to analyze how the system is working. And here we can see this information. I have here the patient, the maximum intercuspal position. Here I have the contacts, the real contacts. I'm not getting the information about the other contacts, only what the contacts that are really happening and without force, without muscle activity. And I can find this contact in a frame. If I look for this contact in the OccluSense registration, I can find these contacts that I find here. But how these patients reach this maximum intercuspal position, it's completely different. Look how many informations we can see. The incuspidation start in some teeth, and with the muscle activity, these patients reach the maximum intercuspal position. Look that she doesn't reach the maximum intercuspal position for a long time. She's not able to keep this contact for a long time, how we see here. And this is very interesting, because when we start using OccluSense, we understand how important and how much difference muscle activities make in the occlusal context. They change very fast and very in a lot of changing depends on the quality of these muscles. And this is normally we don't understand, and we don't have this idea how important it's the quality of the muscle activity to the occlusal context. And this is very, very important to understand. And we can have another information with OccluSense that are the movements. The scans cannot give us this information about dynamic of the movement and for protrusion, lateral protrusion. We don't have this information. And normally what we find is that the signals and clinical problems that we find that the patient brings us, it's related with this movement. So it helps us a lot to view and to understand how the system is working and where are the points of imbalance of occlusion. This is really, really important to understand that scans and OccluSense are different tools that complement one another. They are not one or other. They complement one another and improve the information that we get and that we analyze from the system that we are analyzing, that we are trying to understand where are the problems. So until here, some question, Johnny, or until here, are you okay?
No, all good until now.
Okay.
I use actually the Trios 3 shape also, and sometimes patients are not that they are a little bit confused when I show them on the iPad the OccluSense results. Well, but when I confirm with the 3 shape with the contacts, then they'll be more relaxed, you know, to accept the OccluSense as a treatment plan. It's very good.
I will show you some cases with trios, and I will show you how to adjust and how much change the occlusogram when we make this adjustment. I will show you later.
That's good, thank you.
So after understanding how the informations are processed and how we interpret this data and how we put all these informations together, I organized really steps for clinical applications for OccluSense and how we can introduce this tool to help us to get better results. And now it's a step-by-step and how to use in different clinical situations, when and how to use OccluSense at the clinic. Then when to use. For the first evaluation, what I teach occlusion here in Brazil, and what we teach, it's the whole process of occlusal analysis. What I used to say for my students is, if you do a first evaluation of a very well first evaluation of the habitual position of this patient, you make 100% of the analyze for this patient, and this is the routine. So if we don't understand how this patient is working in the habitual position, it's we started wrong, because it doesn't matter if I understand how is the reference position, how it moves from one and another, from reference position to maximum intercuspal position, if I don't analyze the habitual position for how is distributed the contacts, how are the movements, if I have interferences or not, in the balance side, how it's working the system, and how adapted this system is to this pattern that the patient shows us. So it's very, very useful to understand how balanced is the context of habitual position, and how stable are these contexts, because some patients, they have different positions for the maximum intercuspal position. So it's not a stable system. This is the beginning. If I have a stable maximum intercuspal position, normally this patient don't have problems. Why? Because the system needs some point of stabilization. Even this stabilization happens from skeletal position, from joints, or from teeth. If I stabilize this system in position or in another, the system adapts for this. But the point is, when I don't have stabilization, when I have different possible positions, these systems requires a lot of muscle activity. And this is terrible, because these muscles acting in different positions, it's very harmful for all the system. So if I analyze, if I understand that I can balance better this habitual position that the patient is working, improving the quality of these contacts, balance better between the sides. And look here, I have very large contacts here. When I just balance this position that the patient is working, I get much better results with my clinical procedures, my clinical works. And it's very useful. Sometimes we don't need to change the whole occlusion pattern of this patient. I just need to establish and to balance this occlusion, and the system adapted to this better condition, and we have low side effects of this context, this work. And understand how is the movements from these patients. If I have interference, how this movement is happening, if it's in group, if it's exclusive by canyons, or if I have interferences in the work side or in the balance side. This is very, very important, because when I analyze the occlusion, I have to understand, look here, I have an interference for the movement, the lateral movement, that it's very harmful and very damage, cause a lot of damage for the system, this kind of interferences. This is the side where the joint make the movement. And when I have this kind of contact in the back, in the last molar from this work side, this is really, really dangerous for to find and to have some damages to the systems. And here the protrusion, if we have some interferences, how balanced is this movement? Here we have a good balance with no interference, and it's very, very helpful. This is what we can do for everybody. Every new patient that come to us, we can show them how balanced is this their system, and how we can relate this unbalanced with the clinical claims that they bring us. And this is very helpful to improve the communicate with the patients. When I started in digital world, I started with OccluSense. I introduced the scans and softwares just after, and my communication with my patients when I started to use OccluSense improved a lot, because they can see what we are seeing, and they can, and then after they see, they can feel this interference and this context in the system. We can improve their perception of what we are trying to show them with the graphics from OccluSense. So it helped me in the past a lot how to educate my patients and how to show them the importance of the treatment that I was proposing. So it helped me, and I encourage you to use a lot the OccluSense for the first evaluations, and it will help you to decide the treatments, how you can get better balanced for this occlusion. So another situation, clinical situation that we can use OccluSense, it's for a complete functional occlusal analysis. What is this and how we do this? Complete functional occlusal analysis is when we analyze the habitual position for the patient, how the system is working in the position, the habitual position, to understand how is related the jaw when we have the joints in the stable, skeletal stable position, that is our RP, our reference position. So how, when I put the joints in in a stable position, in a skeletal stable position, how these jaw are related between them, and find the first contact, and then how the system, how is the way that the system makes from this reference position, this stable, this skeletal stable position, for the teeth stable position. This is very important, because normally we use we find the causes, the roots from some problems when we make the habitual position analyze. Most of them we find in this position, but in some cases this is not happening, this problem it's not happening in this position, since in the way from the reference position to maximum intercuspal position. So this is very helpful to understand the whole system, how the system is working, and then make a diagnosis for the problem that the patients are bringing, and then decide how to treat them. So this is a very complete diagnosis flow to understand how the system is working. So it's here we have for this habitual position, the analysis from habitual position, the diagnosis of the first concentric contact, and the context that happen during this movement from RP to MIP. And how do you use OccluSense to diagnose the first concentric contact? So I will tell you that we don't use OccluSense as our first way to recognize this first contact. Why? Because we have muscle activity. And this is much more difficult to do with OccluSense instead of using a software, the registrations from the positions, and use a software to find this first contact. And how we do that? We have the scans from lower and upper jaw. We register the reference position, the relation from the jaw, using a mini reg, that is a disposable from Bausch to help us to register, and we can get the graphic, and then we have the intersection point, and then we register this position for reference position with scan. And here we have used this it's a digital arc, facial bow arc, that it was developed by a colleague, a Brazilian colleague, and we have used with a lot of success to transform the arc. It's not a face ball, but it's like a way to reach the points, the anatomic points that we need to transfer this information from ring axis and the position from lower point here for Frankfurt plan. And then we can have the same data that the facial, the analogical face ball gives us to make a mount in the analogical articulator. But here we use these plans. This is the Frankfurt plan, the ring axis, and the middle line. And then we align this arc, this reference, and then we align these scans from jaws here to this arc, and then we close this lower jaw from the ring axis. This is very important. It's not from here, but the movement, it's done from ring axis. The reference is for this movement, it's the ring axis, and then we get the first contact. This have helped a lot us, because it's very fast and very cheap, and we can do this for everybody, every patient that arrived and start a treatment with us, and we have this complete analysis for everybody. So then when we closed, we can find the first contact. For a software, we know that this contact is a very slight contact. Normally we have more stronger contacts. And when we register the swallowing movement with OccluSense, that is how we get the first contact in reference position and the maximum intercuspal position. It's by swallowing movement. Then I put the sensor and order and give the command to the patient: bite, swallowing. And then we have the first contact, and then the sliding for the maximum intercuspal position. This is how we get this first contact. But when I have a patient with a lot of hip hyperactivity, muscle hyperactivity, this is harmful and very difficult to reach and to understand and to analyze, because muscles are not healthy, and then we can have some distortion of this position. So I prefer to start the analyze with the software, that when I register this position, I used the mini reg, and I don't have muscle activity, and then I don't have distortion of this registration. I find this contact, and then I get this with OccluSense. I have a privileged information to get the informations with OccluSense. And we will understand why it's important to use OccluSense. So, but here I have the first contact here in this molar, And with OccluSense, I got two contacts. This first, that it's stronger, but I found a second contact. And when I looked at, I thought it's wrong. Something is wrong. Where I made some mistake. And I decided to, as I know that this contact is very slight, I decided to close a little bit more this lower jaw here in the software to see what I would find. And I found this second contact, as we have here. But when I look here in the second molar from the other side, I can see another contact, but very slight. Light. And I decided to forward a little bit of this registration with OccluSense, and what I found is these three contacts. These are normally the stronger that we find in a normal occlusion, in a normal contact when analyze the software. So I can find the same information that it's very difficult to register directly here, but I can find. I did this to show you that they work, and even doesn't matter with which tool I'm using, I'm able to register the same information with all. The point here is which way it's easier, which A is more reliable and trust to get this information. I tell you that this registration with the facial ball and the mini reg and the reference position, and then with this information we get this with these other tools. This is much reliable and easier to get. So for all my patients, I do this, and then I use OccluSense with these informations. I must find the same information with OccluSense that I found here. Why? Because here I don't have muscle activity, and here I have. And depends on the quality and how this patient is at that moment, with this some painful muscles and some different clinical situations, I can have this information disturbed. So I trust much more on this way and to get this registration. And let's understand why to get this registration with OccluSense is so important. So just to show you that we have a correspondence between all the flows that we use, analogical, digital, we are able to find the same information. Doesn't matter the way that we have this information, this analyzed. Here it's a analogical mount that we to find the reference, the first contact in reference position, and here is the digital way. And here we find the first contact directly in the mouth, and here with the casts. And what I found, the first contact here, the first contact here, the first contact here, the first contact here, and with OccluSense, the first contact also. So we are able to reproduce the same information with all these different flows. What we have to understand is which tool it's easier and more trust for each flow that we are analyzing. This is very important. And the information about the first contact doesn't give us many informations about this system. What I know is only that I have one tooth that can show us some sensibility because it's the first contact, or sometimes a crack tooth because of this first contact, or sometimes that it shows us that the relation between jaws are very different from what the patients is using in a betal position. But this is an information very poor when we see the whole system. What is really important to find the first contact is to understand how the system comes from this first contact to the maximum intercuspal position. What happens in this way, it's important because normally we have different clinical situations, different problems that happens in this movement. And then here, OccluSense helps us a lot. Why? Because the other tools, the other devices are able only to register the initial, the end position, or the reference position and the maximum intercuspal position. They are not able to show us what happens during these movements. So it's what happened here. I can simulate the reference position and the maximum intercuspal position. And I have the contacts from the reference position and the contacts from maximal intercuspal position. What I don't know and I'm not able to see with scan, it's what happens, how this contact change during this movement. And OccluSense, it's the only device that can show us how this movement is happening. And how we get this information, we get with a swallowing movement. So I have the first contact. Look that I'm not able to register this here. I register a position a little bit after the real first contact, and how this movement I put in a slow motion to show you how to change this contact until the patient reaches the maximum intercuspal position. This is really, really important. Most of time that I don't find the root of some problem in a betal position, I find the root, the cause here in this analysis. So I can show you this movement happening in the mouth. This is a very trained and very conscious patient about these two different positions, and so I can record this movement for the first contact and the sliding to reach the maximum intercuspal position. But how these contacts change, I don't know. I can see only with OccluSense. So I have the first contact, and then she starts to have some contacts to the other side, and then she slides and reach the maximum intercuspal position. So it's really, really important and bring us a lot of information and better understand about how this system is working. Once more, I can simulate these movements with the software tool but not the way the contacts during this movement. I have the reference position and the maximum intercuspal position, but I don't have the contacts that happen during this movement. And here too, the first contact here, and contact here. It's the same case that I showed in the clinical video, and the first contact and the end position that we don't have the information how this movement happened. What is important when I do this simulation? I used a lot this movement. Why? Because I have the trust position, the trust first contact, because I don't have here muscle activity with the registration, and I can understand how is the movement, the direction of this movement from the lower jaw. This is very helpful to understand if I have muscle activity, a lot of muscle activity here in the back, how much this lower jaw turns and in its own axis, and how much I have the middle line distortion. It's helpful, but not for context. It's helpful to have the whole understandable about the system, but not for context. Okay, this is really important. So occlusal analysis, it's done. And how can we use OccluSense for other situations, other clinical situations? I used a lot for oral rehabilitation and in two different moments, for provisional phase and for definitive adjustment. So, for example, I have one case here. These patients came to me with a lot of sensitivity, teeth sensitivity because of erosion, acid erosion from a reflux. And her claim was, I can't brush my teeth because they are very sensible. So I look at, and we have a crossbite here. We have a no good position for these front teeth to get a good static result. And so I need orthodontic movement for this case. But the patient is not able to wait for a movement, orthodontic movement with this situation. So I planned the case, some provisional crowns, and how we can adjust these if I will have some movements. So I planned to balance, not in a perfect distribution, because the teeth would be moved, and I don't have this aim at this moment, but I have to offer to this patient some balance to eat and to swallow and to have some comfort, and I have to keep the space for the movement from these front teeth. And so I used OccluSense to make my decisions and how to balance this provisional phase, and then the orthodontic dentist, or the orthodontist started his job. And so here it's the end of this case. It's the final result with the definitive crowns. And I used OccluSense to refine my adjustment. Many colleagues ask me, do you use OccluSense for all the adjustment? No, I normally use papers that are fast, that are the way that my brain is very well trained. And when I say it's okay, I would be done here with the papers, for me it's good, then I used OccluSense to refine. Normally what I find is that I have a good distribution of the context, but not a good balance. Because the interpretation of the context with papers are subjective. they are not objective. I don't have a number or some objective information to make my adjustment. And what normally I find, it's a very good, well distribution of the contacts, but not the intensity between the contacts. So I use OccluSense to refine this adjustment. And here I had a surprise because I did the adjustment in this front teeth with shim stock, also with shim stock, and I didn't find this contact. So if you remember, we had a periodontal disease here in this place, and in this specific case, I'm not allowed to leave this higher contact here because these teeth will move if this contact keep. It's not higher than the others, but in this specific case, I'm not allowed to leave this contact so higher here. So I adjusted this, and this is the final result that we got, that it's very, very stable. And here it's how we started with the provisionals, and here it's how we end with the definitive crowns. And here it's 1 year after, how stable is this patient and how stable are these contacts. And so the system adapted, and the teeth movement a little bit, and we have contacts between all the front teeth, but in the equal intensity, and we didn't have movement from that teeth. So it's really, really helpful also to register and to documentate how you finished your work, and to have this proof that you end with a high quality of the adjustment in your work. So are we well until here, Johnny?
Yes, sure, perfect. It's very interesting, actually. I love it. Very nice case, the last one.
Yes. This is. I will see this patient next May, and she's at this moment living in Portugal, and then I meet her once a year, and it's really, really stable. She's very helpful with this final result.
That's good. That's very good. I did some bite elevation when you have a vertical dimension that is not adapted or missed or reduced. I did 2 cases with this injectable composite as temporary, and I also found OccluSense amazing in this. It helped me a lot.
Yes, it's very helpful to, it's very useful to help you to decide how to adjust it. When you, of course, that you need to know what you want with OccluSense. But when you know what you want.
It took me a while, actually. It took me a while to understand it the way you are explaining now, because when you buy it, you don't have any training. And I have to discover it myself, and then now I think I'm not bad in it.
Very good, very good. So
yes.
Let's go to the splints and how to use OccluSense to adjust occlusal splints, and how to use OccluSense for control. This is very interesting and very helpful too. Here we have the day 0 when I installed the splint, and normally I don't make a so well refinement for this splint. And why not? Why I understood that the patients that is indicated for a splint has high muscle hyperactivity, and what this splint will do, will relax this muscle, will improve this muscle activity. And so when I spent a lot of time at the first consultation with this splint, I lost time, I lose time. So I take care to refine this adjustment to get balance between the sides and no strong contacts in the front. We used lower splints. This is very important. You use lower splints. And for lower splints, it's very important not to have stronger contacts in the front teeth. This is very, very important. The movement starts in the canines, and then we transfer the contacts for the incisors. And so it's very, very important to have this contact, this kind of contact. And so 30 days after, this is the refinement. So this is what I want. This is the kind of distribution for an occlusal splint we aim. And what is very interesting is that I think that you have too some patients that are not convinced of the importance to use the occlusal splint. And OccluSense helped me a lot to show them how important it is. Why? Because I can show this adjustment of this splint when a patient has a very hard bruxism. And I can show the result in the plate, in the splint, and I can argue with this patient that if you were not using the splint, you were doing this with your teeth. And so it's very helpful to use for controls and to argue with the patients why it's so important to use the splint. Of course, that the splint use, it's very individual, and I use the OccluSense results, what I find in these controls, to individualize the protocol for the patients. Some patients I understand that they are so stable for a long time, and I use this for 30 days and 6 months and 1 year. They are so stable that they are not in a phase of bruxism very active. And so it's not a problem. Don't use one eye and another. It's okay. But some patients, I can show them that the bruxism activity is very, very high. And if we don't use even in short sleeps during the day, we will have problems. And so it's very helpful to individualize our conducts, our protocols for each patient, but based in objective data. This is really, really helpful. And this registration, it's with no filter. I didn't use a filter, and I took this same registration and filtered. Look that we have some contacts here that are false contacts, and when I use filter, I can clean this information. Okay, and after 60 days, I had change of these contacts. So this is very important. And this is very interesting because I have to know for what I'm using that splint. If I'm using for a joint disturbed TMD, I have one aim with this splint. So if this splint contacts are changing for a TMD disease, I'm seeing the change of the joints. But if the patient doesn't have articulation disease, but I'm using only for muscle hyperactivity and protection, these contacts must be stable. And so it's very useful, but this is very important. I must know for what I'm looking for with OccluSense. And then I can use this data. If I don't know what I'm looking for, we will receive so many data that we don't know what to do with all of them. And here I have the second case that I can show you how muscle activity happens. This is very, very interesting. And I started to understand how muscle activity interfered a lot in occlusal contacts when I used OccluSense with splints. And I paid more attention in how contact occlusion between teeth change when the patient has muscle hyperactivity. These contacts are very, very unstable. Here I have how the splint came from the lab. And I have to make some adjustment to balance better this distribution. And here it's how I finished my adjustment. Look that I didn't refine so well. This is not my aim at the first appointment, because I have muscle activity and I know that these muscles will change with the use of this splint, and then I can refine in a second appointment. I can refine better and reach more stable contacts in the second appointment. So I finished at this point, and this is the same plate, the same splint, without any adjustment after 30 days. What is this? Why I don't have this other contacts? Because I don't have hyper muscle activity. And then look that I don't use filter. It's what really is happening. This contact didn't disappear because I used filter. No, it's another registration, but only because the muscle activity changed. And then I refined the adjustment. So it's really, really helpful with splints to documentate these splints and how this patient is going through the time, and to have a very good control of the case and arguments to convince the patient of the importance to use splints. And here it's how that splint came after 30 days. With some contacts in non-work cuspids. And this is the contact after the refinement. And then here we have the register of the movements, only with the anterior teeth, and the very good distribution. So, and for our last clinical situation that we can use OccluSense, it's for post-orthodontic treatment occlusal adjustment. With aligners, we have had a need to add and to balance better these occlusions with adding composite, because we have seen that with aligners we have a very poor finalization of the treatment, and then we are starting to make a mixed protocol. We used aligners, and at the end the fixed brackets to finish this intercuspidation, because it's really poor the refinement of the final phase of orthodontic treatment. But in some cases, we have some limitations, even with brackets, as this case that I will show you, that we had some teeth with, how is the word? When we can, I forgot the name. I'm sorry. We couldn't move some teeth because they were fixed. I forgot the words. I will remember. So this is the initial before.
You meant sclerosed?
It's not a sclerosis. It's oh my God.
Calcified.
It's not a calcified. When it's the root, it's fused with the bone, and we cannot.
I think we call it sclerosed.
Ankylosed.
Ankylosed. Yes, ankylosed. Exactly.
It's ankylosed. They are ankylosed, and we couldn't move some of these teeth. So, but here we have a very bad, very poor relation between the canyons and some. So we made some alignments, improved the inclination of some teeth, and then we could finish with some composite adding. So here it's the finish of the orthodontic movement. We improved the canine position, the inclination of these molars, and improved the relation, and then we can improve this relation between the teeth. But we finished this orthodontic movement without stabilization. We didn't have contacts to stabilize this relation. Look that we had contacts only here, but with no stabilization of the system. So we had to make some add, and then improve this result. So here we have poor contacts with no stabilization. And then we look, and here it's the registration with OccluSense for this final phase of orthodontic treatment. It's very, very poor. And we decided to improve this with composite. And here it's are the teeth with preparations for facets. We had here a problem. This tooth were very wide and ankylosed, foreigner from these, and we have a challenge here to reach static function and with more the more preservation of this tooth that we could, because we have an access for endodontic treatment in the back, and I would like not to destroy it so much. This foreigner, this front structure. So we talked to the patients, and we decided not to solve 100% of the aesthetic, but to preserve some structure and to have function and longevity for these two. So this is the end with the preparations. Here we have an overcrown, the facets, and here some adding in some strategic points to stabilize this system. We will see some changing in this contact distribution. Now I have here, I stabilized this system, and then I could start to work. And here is the final result after the adding the resins. I have much better this contact distribution. We are lacking of this overcrown from here in premolar and the anterior contacts, but we have a much better result with the composite adding. And here it's the final results, the case at the end, with the facet and with the overcrown. And then we can see the distribution of the contacts in very stable positions. and we can stabilize the system with the contacts in the right places. And here it's what I told you about the adjustment of trios. Here I adjusted, when you open the system, this scale is in 2 millimeters. 2 millimeters, it's for prothetic space. It's not for occlusion contacts. So you can adjust this scale for the maximum 200 micrometers or 100 micrometers. And then you have the other contacts more close to what we use with papers in an analogical way. And this is very, very helpful. So I have here the green contacts, what I have when the patients make some force with the muscles, and what these contacts appear. And when I adjust for 100 micrometers, I have more refinable, I have a better understandable where are these contacts. And when I look the final result, I can see that it's really, really well distributed and very stable. This patient is not able to bite in different positions. Every time that I ask him, close, and he closes at the same position. Close, you close, he closes at the same position. This is a sign of stabilization of the system. And here it's the movements from maximum intercuspal for the right side, from maximum for the left side, only with cannons, back to the maximum intercuspal position, and front teeth without interference and very stable. And here it's the final result. As we started and as we finished, we decided not to reach 100% of to solve this yellow color because we preserved some structure. Here I should make a very aggressive prepare to mask this yellow color, and we decided to preserve structure. And here we have the final result, a very stable, very comfortable and aesthetic for this patient. So we finished.
Well, congratulations. I had an internet cut a little bit from time to time because here in Beirut, it's not that good as in Dubai. But after all, everything was very good, and it's really interesting to listen to these things. You always have details. Just one question. You said that it's better to use the occlusal splint on the lower arc, not on the upper one. May I know why?
It's not better. We use in lower jaw. Why we prefer to use in lower jaw instead of upper jaw? Because it's more comfortable for the patient. When I use in upper jaw, I have the volume in the front region of the spleen that difficult to close the lips, and it's this volume, it's very uncomfortable. Normally to sleep, the patients open the mouth because they are not able to keep the lips closed. This is one reason. The other reason is to speak. Some patients sometimes need to use this splint during the day. It's not always, it's not all, but some of them need to use to make some exercise or some specific situation that they plant, and so it's easier to speak. Yeah, when I speak, I need to to use the tongue in the front region of the upper. And when I have the splint upper in the upper jaw, it's very difficult to speak with it. And then when I use lower
sorry, I understand. So this is mainly for speech. It's not on occlusion purpose.
No, it's not for occlusion purpose. The occlusion purpose I can get with both.
Okay.
We decided to use lower splints only for the comfortable. It's more comfortable for the patient. It's more acceptable. They use more than when we use upper. And when we have to use during the day, it's easier to the patient use them. But you can use both.
Okay.
It doesn't matter upper or lower. It works if it's very well adjusted and makes the function, it works equal.
Great. Thank you so much. All was very good, very interesting.
I thank you. More questions?
No, I'm fine. Thank you so much. Thank you for your time.
Have a good Saturday, a good weekend.
Yes, you too.
And you had my contacts. I don't know if you saw, and if you have
no,
questions,
actually, I didn't. Where are they?
I will share with you. If you have some doubts, you can contact with me by Instagram or email.
Okay, let me take a screenshot. Yes, done. Thank you.
Very good. So, thank you for your presence, for your attention, and see you in the next slide.
See you. Thank you so much. Bye-bye.
Bye-bye.